She currently serves as the Director of the Health Innovation. She's Executive Director of the CEO Council on Health Innovation at that Bipartisan Policy Center. Also supports National Coordinator of Health IT and served as the CEO of eHealth Initiative. She is also the COO of National Community for Quality Assurance. Please join me in welcoming her, Janet Marchibroda.
Thank you, and good afternoon. It's a great honor and pleasure to be joining you this afternoon. Spent a lot of time in Georgia. Look forward to getting caught up on all the exciting things that are going on. So it looks like folks are still finishing their lunches. I thought what I might do is tell you a little bit about our work at the Bipartisan Policy Center, particularly as it relates to leveraging all of the investments that you all are making in health IT for what's coming in healthcare. So we'll spend a little bit of time there, and I'm hoping you can jot down some questions. I'd love to ask you some questions, get a sense of what you think about our recommendations, what's coming up. I know the CIOs this morning talked about a number of your challenges. Boy, is there a lot of change underway in the health IT arena, so I'm hoping we can talk a little bit about that. So who is the Bipartisan Policy Center? Why are we focused on health IT? We were actually formed in 2007 by former Senate Majority Leaders Tom Daschle, Howard Baker, Bob Dole, and George Mitchell. Senate Majority Leaders, both sides of the aisle, and the whole idea around the Bipartisan Policy Center was to find common ground, to find a place where Democrats and Republicans could have conversation, figure out a common path forward. And boy, oh boy, it feels like a lot of that is needed today, doesn't it? Our roots were in energy, did a lot of work in energy, done some work in immigration policy. We had Governor Barber, Governor Rendell, Condoleezza Rice, and others come to agreement on how we might move forward on immigration. And of course, we're looking at healthcare. And I'm going to tell you a little bit about that during my talk today. So what are we doing in health? We've got a pretty large health program. We're focused on 3 areas. We've got health policy, and I'm going to tell you a little bit about one of our reports around cost containment. I guess that's the word of the day. We released earlier this year with leadership by Pete Domenici, a Republican, Alice Rivlin, a Democrat, Bill Frist, former Senate Majority Leader Bill Frist, a Republican, and former Senate Majority Leader Tom Daschle, a Democrat, some recommendations for how we might contain costs in healthcare, so lots of cuts. And then I'm going to share a little bit that would be most probably interesting to you, this audience. What we also do, so Catherine Hayes leads that effort. I happen to lead an effort called the Health Innovation Initiative. And what do? We really focus on ways to leverage information and information technology to drive improvements in the quality and cost effectiveness of care. And I'm going to share a little bit of the work that we produced over the last couple of years, and then I'd love to get into some conversation. Again, there's lots of change going on. A lot of what we do is a status check. How are we doing with our investments? Where are mid-course corrections needed? And the input we get will be important because we're in the middle of developing some additional recommendations. 5 years back, high-tech investments, what's going well, what's not going well. So would love to talk a little bit about that with you today. So I don't need to, you've seen all of this about rising healthcare costs being at 18% of GDP. So big problem. Some of the estimates say that we're leveling off off in growth, but it's clear that this will continue to rise as all of us in the room get older, baby boomers primarily, and as we get older, we're going to have more things wrong with us. We're going to be using the healthcare system, unfortunately, a lot more. So lots going on in that area. The other important thing, and it's the big conversation right now, as you know, as we look at sequester, the federal budget, what to do. You know, healthcare is probably the primary driver of debt in the United States. So it's not just a healthcare problem, it's an economic problem for us, as you well know. Some other statistics here before we get into the content. We lag behind other, even though many would say that we have some of the best healthcare in the world, it's also the most expensive, and this compares us to other countries across the world. And so if we spend more, wouldn't that mean that we had better quality? Well, I guess at least based on the measures that are captured by different countries across the world, not so. So we've got a lot of work to do, and that's why I know all of you in this room are working so hard on building that information foundation, making those health IT investments, because really they play a foundational role in improving the cost and quality of care. And now as the rubber hits the road, as these meaningful use investments move into clinicians' offices and health systems and hospitals, and I know we've heard a lot about that today, it's really important to make them count. And I guess what I'd want to ask you, I've got insights from about 40 organizations about whether those investments are counting and what can we do to make them better investments if needed. Just a final data slide before we get into the content. The other component, and I know a lot of the delivery system and payment reforms that are moving into place are around addressing increased prevalence in chronic disease. And again, this gets higher, prevalence gets higher as all of us get older because there's so many of us moving into older age in our healthcare system. And here's just a slide that shows that people with chronic conditions account for 84% of spending. Okay, so let's get into some policy now. In our report, and if you're into policy, want to think through different policy options for containing costs in healthcare, I encourage you to go to our website, www.bipartisanpolicy.org, and pull down our April 2013 cost containment report. It's a pretty thick read. It's probably 3.5-hour plane ride, so if you're headed to the West Coast, or maybe further west, you'll be able to take it in. But it's pretty interesting. And there have been a lot of cost containment reports that have been released over the last few months. But this one was pretty important because you really needed to take it as a whole. It had support. There was agreement amongst Republicans and Democrats, the leadership that I shared with you, that, you know what, we could live with this. This is workable because we are going to need compromise to figure out how to reduce healthcare costs. The other important thing is it was based on data. We had we purchased the CMS database, all the healthcare data, for the last 3 years, and we ran the numbers to see if they would score. Because for those of you who don't follow policy, you can't just make a recommendation and it gets done. You need to convince a lot of economists that will actually save money, it'll pay for itself, and the like, in order to get policy passed in our country. So let's dive in. I'm looking at my watch, and maybe spend about 15 or 20 more minutes on the background before we dive into some discussion. So, strategies to address rising healthcare costs. You've probably already talked about this today, but the biggest driver, right, around rising healthcare costs is we mostly in our country pay for doing more instead of doing well. And so our fee-for-service-based system rewards you if you order more lab tests, prescribe more, have more visits, do more imaging, just do more. It rewards, it pays more for the more that you do, but it, outside of some pockets, and we've got lots of experiments coming out there, it doesn't reward you for doing well. So that's a big driver of healthcare costs in our country. The second is this fragmentation and the fact that things happen in silos, right? There isn't much communication across specialists, primary care, and hospitals. We think that's changing. I'd love to hear about how things are going from your perspective around care coordination. The other thing, and I know the other thing that's important, and there's been a lot of good work going on in different states, is the fact that we really don't have very much information. So we all make decisions about other parts of our lives based on cost and quality. You know, go online, you look at the ranking, you figure out how much do I want to spend. You look at value. Well, not so in healthcare. It's pretty opaque. We don't have very much transparency in the cost and quality of care. And that drives up healthcare costs. And there are a lot of discussions underway around making that information more transparent. I know Senator Wyden, there's a lot of policy out there calling for more transparency. That'll be a little scary. I think we're gonna have a rocky road in getting there. All sorts of issues that hopefully we can talk about during our discussion, but is really needed in order to drive down healthcare costs. And of course, legal barriers, fear of malpractice, liabilities are driving up healthcare costs. And then something that's just happening generally, we're seeing more people get older, more people getting sick, more people with chronic disease, and that's also a big driver. So what I have here on the right are a number of recommendations or strategies to address each of those barriers. The next thing I'm going to do, so follow me here. We haven't talked about IT very much, but what are the drivers of cost? What are some of the strategies that can help reduce costs and improve quality? And how does Health IT play a role? And then where are we encountering some challenges? So this is a few months ago, we actually did a study. Senator Daschle and Senator Frist oversaw a task force made up of senior leaders, chief executives representing employers, consumers, hospitals, health plans, and of course, the medical profession, to take a step back, because there were $30 billion of dollars invested in health IT. Remember the thing called high tech? And what we wanted to do, given there was such movement in accountable, whatever you want to call them, accountable care organizations, accountable care models, patient-centered medical home, a lot of those were moving forward. And we wanted to understand what the information needs were of those new models of care. Leaving the health IT aside, right? Just understanding what do you need in order to make this work. We collected that data. Let me see. We collected that data, and then we got a set of requirements, using IT language, if you will. We got a set of requirements for accountable care, new models of care. We compared it to what was going on in the US today, and then we found a bunch of gaps that I'm going to share with you, and I want to test with you during our discussion. Before we get into it, though, all these new models of care, whether it's an ACO, by a raise of hands, how many of you are involved in a new delivery system reform effort today? Any? So not that many. So is there a lot of delivery system reform, or a lot of the hospitals starting to work with the physician offices to coordinate care here? No, I did. Anybody involved in that? Okay. Oh, great. Yes. So there's a lot, billions and billions of dollars invested in these new models of care across the country. There's about $10 billion invested by the federal government. A lot of the states are investing, and all the major health plans are actually implementing what folks loosely call accountable care organizations. And I know there are some issues and some fine-tuning that's needed, just like you need with any policy. But this is really moving across the country, and many believe, when I talk to all the major health plans, that this will be our new model for payment in the future. A number of health systems are also, as you see here, 227 provider organizations across the country had established ACO contracts with Medicare, Medicaid, or private payers. So basically, just taking a step back, well, what does that mean? What is accountable care? It's basically, and again, there are a lot of formal definitions, but I'm going to give you one at 20,000 feet. It's a model where remember I said that payment was primarily based on if you did more, you got paid more. Well, in these new arrangements, actually there's accountability, and physician groups, specialists are working with primary care or working with hospitals, sometimes long-term care facilities, and they're working together to manage the care for a certain patient population. And then they're getting paid more if they do it well, paid less. Again, we're gonna get into the technicalities. There's lots of different models, but in essence, they do better financially if they manage to better outcomes. And overall, the thinking is that you actually drive down healthcare costs because you're managing a patient population. In the old days, a lot of this happened with health plans. Remember that? Like 80s, 90s, I don't know how old our audience is. But this new wave is being led by providers, primarily. And in talking with a lot of small physician offices, they're saying, you know, I've got to get myself ready. I've got to be competitive to be part of these new arrangements. I don't want to be left behind. The hospitals are saying the same thing. And so you're seeing a lot of these crop up across the country. We already talked about some of the drivers. CMS, Medicare is putting a lot of money into this. So, our methods, and I'll get to the content really quickly here. So what we did is we interviewed 40 high-performing organizations across the country, got on the phone, said, tell us about what you're doing. And how did we get to this list? We did a literature review. We looked at who got awards from CMS for accountable care. And we asked them, well, what sort of information do you need in order to be successful, in order to drive better costs and better outcomes? And then we captured that, and I'm going to go through it right now. So the first question was, you know, what are the common aspects? You know, what are the common attributes among you? What makes you successful? And it really came down to 6 primary areas, and I'm going to go through each of them pretty quickly. The first, and this was common amongst all of the high-performing healthcare organizations or healthcare arrangements. You know, if you looked at that list of 40, it's a combination. The Vermont Blueprint for Health, Banner Health, you know, a whole range of different organizations, Geisinger Health System. Well, the first thing they told us, of course, this makes sense, right? But it isn't true across the board, that they have strong organizational and clinical leadership, right? And so I'm going to start tying this into health IT a little bit in the interest of time, because I'm looking at my watch. So their leaders know how they're doing, right? You do that normally with all the management. They know how they're doing clinically. How are they going to know how they're doing clinically? They're going to need to rely on the systems that you're installing within your healthcare systems. And this is pretty hard to do in the old days, and even in a lot of institutions today, they get that information by pulling charts. Well, now with the electronic health records that you're installing, they're able to capture a lot of that data along with claims data in order to assess quality and cost. Sounds pretty simple, right? In any other industry, real easy to do. Healthcare, not so easy, really hard. And there's a lot of smart people in the country right now trying to figure out how to make sense of the spaghetti out there. Because, as you know, a lot of the data that you need, whether it's lab data, like what lab tests were performed, what were the results, how much did they cost, what drugs were prescribed, what were the diagnoses, how do I identify the patients, how do I identify the providers, and you know what? All of that data, you know better than I do, it sits in different places, right? So you gotta connect it to figure out how you're doing in terms of quality. For Mrs. Jones, did she get the immunizations she needed, the tests she needed? Did she get the same test 5 times, right? Were there adverse results? Did it cost too much? All right, so strong organizational and clinical leadership. The other thing that they said, which was important, and you don't always see, is you've got clinicians as part of the leadership team. Okay, seems like a no-brainer, right? In healthcare, it doesn't happen all the time. And so recognition of having clinicians be part of leadership is really important. In the interest of time, healthcare IT plays a key role, and you've got to be able to combine different data sets that sit in a lot of different places to get this done. Okay, this is the second thing that's really important. High-performing organizations recognize, again, seems like a no-brainer, but doesn't happen. I'll tell you, in interviewing the 40 high-performing organizations, it happened less than half the time, and they were really frustrated. So in a high-performing organization, all of the folks that take care of us, Janet, whether it's my specialist or my primary care doc, or if I was just discharged from the hospital, all of them have access to information. So they have access to information about me, and you'd think, no brainer, right? But it's not happening, and that's probably one of the biggest gaps. And I know that Georgia is doing a lot in the way of health information exchange, and I'd love to talk about that more with you. Timely access to care. Now, this wasn't an attribute of all 40 that we interviewed, but it was predominant enough to make it onto the list. But these high-performing organizations actually make it easy to get access to care, because they recognize if you get in early, before things go poorly, you can actually reduce healthcare costs. And so access is very important. Fourth, and this is actually, we didn't talk much about my background or my work. I'm spending actually a lot of time in this area working with a number of chairmen and CEOs of Fortune 50 companies, a couple here in the Atlanta area, on how do we improve the health and wellness of employees in our country. And that plays, I don't know if you realize this, but only about 10% of outcomes are reliant on the healthcare delivery system. A lot of it has to do with our environment, our genes, and our behavior. Our genes meaning our, how we're made up as individuals, as humans, and our behaviors. And so if we just focus on the delivery side, and I know my talk's most about delivery, it's not sufficient. You can do a lot just working with individuals. So BPC and our Health Innovation Initiative is doing a lot of work in that area. And then finally, of course, accountability, and we've talked a lot about that. Aligning incentives is key.